The last but not the least in this session is Dr. Mariam Al-Awadi. Dr. Mariam is a neurologist at Ibn Sina Hospital. Dr. Mariam had a degree in neurology from Kuwait Neurology Program in neurology, and she is going for her fellowship now in a movement disorder, and she will tell us about a very important topic in a movement disorder, which is approach to a patient with tremor. Dr. Mariam, the floor is yours.
Bismillah ar-Rahman ar-Rahim. It's really an honor to be here among my mentors. Thank you so much, Dr. Jassim and the organizing committee, and thanks to Dr. Mish'al and Dr. Suleiman for their continuous support. I'm going to talk about approach to a patient with tremor. This is my outline. And first, we'll start with a little bit of history. The first descriptions of tremor in the literature, if you go back and review it, were mainly in the 19th century, in the 1800s. And the term essential tremor was first introduced by an Italian doctor in 1874. And this is actually the cover of that journal. Of course, interestingly, there are many contributions by Dr. Parkinson's, Gowers, and Charcot, and many other in the history of tremor. What is the definition of tremor? It is an involuntary movement disorder which involves rhythmic oscillation of a body part. It results from contractions of agonist and antagonist muscles usually. When it comes to classification of tremors, there are many classifications and way to categorize tremors, and some of them can be really confusing and some of them are based on activation condition, for example, rest or postural tremors. Some are based on the body parts involved, for example, a head or a voice tremor, and others are based on the characteristics of the tremor itself, like frequency or amplitude. And other references also categorize tremors based on etiology. For example, is it due to neurodegenerative disease or metabolic or drug-induced? This is one table which describes tremor in terms of the activation condition, or and divides it into resting tremor, postural tremor, and intention tremor. And of course, you can see the wide list of differential. For example, resting tremor is mainly due to Parkinson's disease, but there are other diseases as well. Postural tremor includes physiological and enhanced physiological tremor, as well as essential tremor and primary writing tremor. As for intention tremor, it usually involves diseases of the cerebellum or cerebellar outflow tracts, and can be due to multiple disorders like MS or vascular disease. I like this simple way to categorize tremor based on its activation condition, or the state at which we can elicit the tremor. It's divided simply into rest or action tremor. And there are subcategories under action tremors, including postural tremor, isometric tremor, and kinetic tremor. And in turn, kinetic tremor is also divided into intention or task-specific. When we say kinetic tremor, we mean that it is usually present throughout the movement, whereas intention is mainly exacerbated at the end of the targeted movement, or sometimes we call it terminal even. We cannot talk about classification without pointing to the most recent consensus statement of classification of tremors by the Movement Disorder Society. This was actually developed in order to help further classify tremor syndromes, especially tremors like essential tremor, for example, which we will be talking about later. And it is based on two axes of classification. The first axis is uses clinical features or that characterize the tremor itself, and these include historical features and findings on examination. In addition to any relevant laboratory tests. The second axis is based on etiology, and it's divided into acquired, genetically defined, and idiopathic. This type of classification really helps to define, for example, isolated tremor syndromes, and it helps mainly in communication between physicians and also in research. Now we'll come to the main point of our topic, which is the approach to a patient with tremor. And as we all know, in most diseases of neurology, this is based on history and examination. So first we'll start with the history. Importantly, the age of the onset. It is very important to know, as well as the temporal evolution of the tremor and what are the body parts involved. Is it only one part? Is it, for example, the upper limb? Is it both upper limbs, and which one started earlier? And also, what are the positions that bring on the tremor? This may be elucidated during examination, but some patients may volunteer that, for example, telling you that I suffer from tremor while eating or while writing and so on. And is this the tremor task specific or not? And this is very important as well. Is there a pulling sensation or pain, which may imply that there's an underlying dystonia there? And of course, we have to ask about any other associated neurological symptoms, including imbalance, for example, and importantly, slowing of movement or difficulty with gait. And we should also try to see whether there are any relieving factors that alleviate the tremor, as well as aggravating factors, for example, stress or caffeine or certain medications. Systemic review is a very important part of history taking in tremor. We have to specifically ask about symptoms of hyperthyroidism, for example, which can lead to enhanced physiological tremor. Of course, drug history is a major part in any movement disorder, and we have to cover it thoroughly. Family history is also important to ask about. Social history in some may be relevant in some cases, for example, in occupations where precision or accurate movements is required, like surgeons, for example. These people will really discover the tremor earlier than others. And a very important part of the history is to ask whether the patient is disabled by the tremor and whether it is affecting their daily activity. This will help you in determining the treatment, because not all tremors require treatment, especially early on. Now we go to the examination, and as we all learned in medical school, we start with inspection. As the patient comes into the room, we have to look at their gait, whether there's any tremor accentuated during walking. We have to look at the facial expression, whether there's any masked face or increased drooling, reduced blinking rate. And once you finish with the general inspection, you go to examine specifically for tremor. And there are, of course, different positions to examine for tremor. The first one is while the patient is relaxed on the chair with their hands on their lap. You can observe and wait for the tremor to occur. And if you don't see the tremor, you can use certain maneuvers like distracting the patient, or using mental tasks like serial sevens, for example. Another helpful position might be resting the wrists on the arms of the chair and hanging them there. You might also see the tremor in that position. The next important position is the outstretched arms with the fingers abducted, and we'll see videos clarifying that. So in this position, you have to look whether there is any postural tremor and whether there is re-emergent tremor, which is specific mostly for Parkinson's disease. Also in this position, you can look for any posturing or any changes in posture, like for example, abduction of the little fingers and so on, which may indicate dystonia. Another position include the so-called wing beating position. It involves abduction of both shoulders and flexion of the forearms at the elbows, and putting the hands next to each other without touching. And here you can really notice the proximal tremors. And usually we refer to wing beating tremor in case of Wilson's disease, but it can be seen in other conditions as well. We have to observe for any parts involved with the tremor other than, for example, the upper limbs. We may see tremor in the head, and we may also notice that the voice of the patient is tremulous. We have to describe the amplitude and frequency and the rhythmic movement of the tremor. As we already said, we use mental tasks to help us. The maneuvers that are important to examine for during tremor assessment include finger nose testing, and also importantly, for example, for essential tremor is to see whether activities like drinking from a cup or pouring water into a cup back and forth between the two hands and are also helpful. Also, writing is a very important part of the assessment. For example, micrographia in case of Parkinson's disease, as well as the Archimedes spiral drawing, which can be helpful also on follow-up assessments of the patients before and after the treatment. We have to look for any other neurological features, importantly, bradykinesia and rigidity, which should not be missed. This is an example of the Archimedes spiral. Of course, this is a patient with essential tremor, and we can see that they're asymmetrical. This is in each, in the right and in the left. We have to note that the hand should not be resting or leaning on the desk while they're drawing it. Okay. So to continue the examination, of course, you have, based on your differential diagnosis, you have to look for other features. For example, any abnormal extraocular movement, abnormalities with coordination and ataxia. Gait is a very essential part. You have to notice whether there's any difficulty with initiating or standing from a sitting position, and whether there is slowing of the gait, or there's any exacerbation of the tremor while walking, and whether there is any reduced arm swing, for example, and so on. We have to look for specific signs depending on the clinical picture. For example, if we think the patient has a functional tremor, which is really a diagnosis of exclusion, we can use certain tricks like suggestibility and entrainment in order to help us further define the tremor. And of course, we have to complete our neurological examination. So thank you, Dr. Wala, for helping me with the videos. This is a patient resting with the hands resting on her lap. You can see, I hope it's clear, there is a tremor on the right, in the right hand. This is a resting tremor. And also we can ask the patient to put her hand supine, in a supine position. Okay. The next case, this is a lady with essential tremor. Okay, we can see the hands resting, and it's important to note that even essential tremor can have a rest component of tremor. This is the outstretched arms, and you can notice that immediately she had the tremor, and it can be asymmetrical. It looks like it's more on the right side. Here, you look at the kinetic tremor and the intentional movements as well. So as this is the finger nose testing. So at the end, really, there's this component of terminal or intentional tremor, which is severe in this case and can be very disabling. Okay. So always look for any associated features and keep your differential diagnosis in mind. Now we move on to the investigations of tremor, and this is also based on your patient. You start with the routine lab tests, CBC, and electrolytes, and you have to look for any metabolic derangements, including liver enzymes and thyroid function tests, importantly. If you think the patient, for example, the patient is young and presenting with other features other than tremor, you have to look for evidence of Wilson's disease. It is a treatable disease, and it can be fatal without treatment. So you have to look for 24-hour urine copper, which will be high in case of Wilson's, and also serum ceruloplasmin, which will be low. Additional testing might be required. For example, if you still have a suspicion of Wilson's, you may use slit lamp examination. Imaging like MRI can help, for example, in neurodegenerative diseases, while DAT scan is used in some cases which cannot, for example, differentiate between essential tremor and Parkinson's disease, and in other situations. So you have to tailor really your investigations depending on your patient. Now we move on to examples of tremor. Rest tremor is present when the body part is at complete repose, completely at rest. This, of course, Parkinson's disease is the most common cause of rest tremor. The frequency usually ranges between 4 and 6 hertz. It is typically a pill rolling tremor. It looks like as if the patient is rolling a pill in between their thumb and middle finger. However, this is not necessarily the case. The tremor might be of flexion and extension at the wrist, or supination and pronation. So also you have to look for re-emergent tremor. We will see in the video, what is a re-emergent tremor? You ask the patient to outstretch their arm. Usually for a few seconds, the tremor will disappear, and then it will come again. It will re-emerge as the patient sustains the posture. And it's really often associated with Parkinson's disease. Patients with PD can have postural tremor as well, so it's important to keep that in mind. Now, always remember that not every rest tremor is due to Parkinson's disease, and not every patient with Parkinson's disease will have tremor. We know that many patients with Parkinson's will not present with a tremor. So other causes of rest tremor include drug-induced, for example, is the patient taking antipsychotics or antiemetics, also other neurodegenerative diseases like MSA, or some types of spinocerebellar attacks. Yeah. Patients with ET, importantly, may have a rest tremor component as well, although this is not the main component. So this video will show you a patient with Parkinson's disease. Okay, you see that while resting her wrists on the armchairs, you can see the tremor. I'll repeat that. So you can see first the resting tremor, sorry. You can see the resting tremor here. And once she is asked to outstretch her arms, for a split of a second there, you can see that tremor goes down, and then it is worsened again, becomes really severe. So it's usual, this is considered to be an re-emergent tremor, although the pause between the re-emergence of the tremor may be longer than that. Okay. Next is Holmes tremor. This used to have many other older terms, including rubral tremor or midbrain tremor. Those terms are not used anymore because it has been discovered that it's not really only due to a midbrain or red nucleus lesion. It's usually unilateral and of low frequency of 3 to 6 hertz. It has 3 components. Intentional, postural, and rest. Usually the intentional component is the worst, and then it is more than postural, which is in turn more than the rest component, and it can be very severe and disabling for the patient. The lesion may be found in the pontine midbrain region, or it may involve the cerebellar outflow tracts and the dopaminergic fibers. It may also involve the thalamus. Causes include demyelinating disease, stroke, and tumors. Other neurological signs are usually associated with Holmes tremor, including dystonia and ataxia on the same region of the tremor. Treatment may include levodopa, because as we said, the nigrostriatal pathways may be involved, and dopaminergic fibers may be involved in this tremor, and other medications as well. In severe refractory cases, the DBS may also be considered. This is a patient who has severe multiple sclerosis and demyelinating disease, and you can notice that on the left side, she has Holmes tremor. She has postural tremor, and the worst really is the intentional tremor as she tries to reach for her nose. It's very difficult. The right side is not really that affected, but it is mainly on the left side. Okay, so intentional component is the worst in case of Holmes. Okay, head tremor. This is if we see an isolated. Just wanted to point out that we see an isolated head tremor, which involves the shaking of the head. It can be in a yes, yes, no, no position, or it can be variable really with a rotatory movement. So it's not necessarily yes or no. And if we see it isolated, we should think of dystonic tremor. Also, another common cause is essential tremor, although a classic essential tremor will not have isolated only a tremor. Of course, cerebellar disease may cause also titubation of the head, so it's always important to keep in mind. Very less commonly, PD may be associated with it. Now, this is the last part of my talk, essential tremor. It's probably the most common, one of the most common movement disorders that we know. It is characterized mainly by postural tremor and accompanied by kinetic component, mostly involving the upper limbs. Distal tremor, it is a distal tremor most often with extension and flexion of the hands. Frequency usually varies between 4 and 12 hertz, and it can be asymmetrical. So it's important to keep in mind that not necessarily that they will have the same severity on both sides. Family history is very important. From the literature, we know that there must be hereditary factors involved in essential tremor, although there are many studies, the exact genetic factors have not been clarified yet. And those patients can have head, voice, and lower limb tremors as well. It can be very disabling for the patient. The origin of this tremor is mostly a central oscillator involving the cerebellum and its pathways. Also, there might be a role of the VIM of nucleus of the thalamus. The published ET criteria by the International Parkinson and Movement Disorder Society include isolated tremor syndrome of bilateral upper limbs action tremor, at least 3 years of duration, because initially you might only have the essential tremor, but later on, if you follow up the patient, you might find additional features. So you have to wait in order to finalize your diagnosis. And it can be with or without tremor in other locations, and there is absence of other signs such as dystonia or ataxia. This is the classical essential tremor. Another type of essential tremor is called essential tremor plus, and this is characterized by tremor with the characteristics of the ET, which we mentioned already. In addition to other signs of uncertain significance that are not enough to make an additional syndrome diagnosis. For example, there might be mild impairment of tandem gait. There might be questionable dystonic posturing. So soft signs, really. Theoretically, this may sound simple, although in clinical practice, it might be really difficult to determine which one is mild and which one is a soft sign. They might also have some mild cognitive impairment. This is my last slide, management of essential tremor. It includes medical treatment as well as assistive devices. Assistive devices can help make the lives of the patients easier. They can include some special utensils or pens in order to use in daily life. Medical treatment, including the most commonly propranolol, beta blocker, and primidone. They can have very good results. Other agents include benzodiazepines and topiramate. In advanced refractory cases, we can use deep brain stimulation, and there are many studies now on focused ultrasound thalamotomy. I will end with this video. This is the same patient that we saw before who had essential tremor and was very disabled by. This is following DBS. This is post-DBS. So this is at rest. You cannot see much of the tremor. And once the arms are outstretched, it's really remarkable change after DBS. So we see the kinetic component, improvement in the quality of life of this patient. Okay, and also you assess the other side. And here the finger nose testing is also, or finger chin here, is also improved. Okay. The spiral also drumming is very important follow-up. These are my references. Thank you so much for your attention.